meeting of the Microsurgeon Weekly webinar. I'm Dr. Mansoor from Pakistan, and I'll be the moderator today session. Before starting, I would like to introduce the spirit behind the Crazy Surgeons. It is a celebration of creativity in aesthetic and reconstructive surgery driven by zeal and passion. Here, age is just a number, and the energy, innovation, and brilliance of our contributors remains ever youthful. So, you can join us by contacting our organizer of the Crazy Microsurgery Club by contacting at this email. Today's speakers will be, as usual, our sensei, Professor Sakushima, and he'll be talking about the AI analysis and various flaps for genitourinary reconstruction. The second guest speaker will be Dr. Nyoman from Indonesia, Bale, Indonesia. From his topic will be from LDMC to TDAP, my learning curve. Professor Newman is a plastic reconstructive and aesthetic surgeon and educator from Bali, Indonesia, with a PhD and advanced surgical fellowship from Showa University, Japan. He has led clinical services and reconstructive microsurgery and burn care. As a former president of the Asia Pacific Burn Association, currently as an honorary board member and a recognized researcher in novel reconstructive technique, uh, both clinical and excellence and innovative scholarship to our session today. This Professor Kushima, we all know, he inspired many around the world by his futuristic ideas, which always keep him ahead of time. He pioneered and established perforator flaps, capillary perforator flaps, lymphatic surgery, skull-based surgery, digital reconstruction, and peripheral nerve surgeries. He has more than 1,000 publications, including books, articles regarding his techniques. So we all know about Professor Kushima. Now I would like to invite Professor Ryasa to start with his topic. Thank you.
Thank you, Professor Mansoor, for the very nice introduction to my honor Professor Cosima. Always say thank you from me for the opportunity to share just my small experience from my beginning as a plastic surgeon until now, still learning and also learning from you. So that's why my topic right now is regarding LDMC flap and TDAP flap. Yeah, that is an expression of my learning curve. Yeah, so in Bali, Indonesia, I actually start my career as a plastic surgeon by establishing a burn unit. Yeah, so that is my first career. That's why my cases in the early of my career is mostly how to develop microsurgery for burn patient. Yeah, so that's why the case is mostly burn. And one of my favorite flap is LD flap, actually. Yeah, and as a young plastic surgeon, this is a very easy to harvest, especially at the time. Yeah, but by the time I try to develop some innovation. As we know that latissimus dorsi, according to Matis and Nahai classification, is considered as the type 5 of muscle flap. So the flap, the muscle of major blood supply from the thoracodorsal artery and other minor blood supply from the dorsal intercostal arteries. Yeah. So the subscapular system is actually consists of at least three system that we could harvest as a flap. Yeah. And the thoracodorsal artery that is gives supply to the latissimus dorsi is very, very important. And also the scapular from circumflex scapular artery, also very important armamentarium flap that we could harvest. And also, if we look in more detail about the thoracodorsal artery, yeah, and this artery give branch to the muscle as a perforators, muscle perforators, and also to the skin. Yeah, so we could harvest this flap actually based on these perforators, but as a young surgeon, I mostly like harvesting the flap, even though that is a perforator flap, but I harvest a longer pedicle, yeah, that will give more freedom and also much more easier when we doing anastomosis in a difficult situation. So my learning curve is actually starting from the simple one as a harvesting the flap as a latissimus dorsi flap. Yeah. So I make some classification according to my progress. Yeah, this is just my personal development. So I divided it first as a type 1 as a LD flap. So we could harvest the whole LD muscle or split the muscle. Yeah. And also we could harvest as a composite with the skin. Yeah. So the whole muscle or the split latissimus dorsi muscle with the skin, yeah, as a musculocutaneous flap. This type of flap also could be what used as a pedicle flap or a free flap. Yeah. And the purpose is the fat coverage, and also could be used as a functional muscle transfer, yeah, in a pedicle flap. And then from this stage, from the first type of flap that I mastered, and then I start developing the type 2. This is wrong. I'm sorry, I'm wrongly put. Type 2, a compound flap. Yeah, I call it a compound flap. Yeah, because this flap split the LB muscle, and then also use the skin, but with thin subcutaneous tissue. And this flap I use as a free flap mostly, and the purpose is the fat coverage and also functional transfer. And then from this type of flap, compound flap, I start develop the perforator flaps, yeah, that is thoracodorsal artery perforator flaps. With the I harvest as a thick flap, a big flap, or a thin or small flap, yeah. And this also could be used as a free flap or a pedicle flap. And mostly this is for the fat coverage. And the last is, of course, the chimeric flap. And I learned this from Prof. Cosima, so I could use the muscle and also the skin as thoracodorsal artery perforator flap, and also using the scapular bone. So this is just my progress, and until now I'm still learning how to use this flap. So in this presentation, I just give example only, maybe 2 or 3 cases for each of this stage. Yeah, I'm not able to do analysis for a moment. Yeah, but I hope in the future maybe I could do that as shown by Professor Cosima. So for now, I will give the example how the progress in harvesting this flap and use this flap. So this is my early cases and when developing the burn unit, and then develop and incorporating microsurgery service into burn unit. So we receive referral of a patient, lady, 56 years old, with burn on the facial and also on the scalp. Yeah, this is due to scalded hot cooking oil. So she got epileptic seizures, and then embodied the face and the head on the hot oil during cooking. Yeah. And the patient blinded, so totally blind, and the granulated tissue until 4 years. Yeah, 4 years. The patient finally came to me. Yeah, and in this case also we see the expose of the frontal sinus. So as a young surgeon, this case, I just thinking that maybe the latissimus dorsi is the big flap to cover this. So that is why I choose latissimus dorsi. So I call it as a type 1. I harvest the whole latissimus dorsi and a skin pedal, and skin pedal on the top of the vertex I put there. And the rest of the muscle, I put skin graft. Yeah. Of course, before the this procedure, I also release the palpebra here, but cannot give really a good result. And then 3 weeks after operation, the sinus cannot be filled with the muscle. So I decided to harvest another flap from the lateral arm flap and cover the frontal sinus and also give some soft tissue on the forehead and on the orbita. So this is the final result that I got from this patient, and the patient could use artificial hair and also like sunglasses just as a cosmetic adjunct, and the patient and the family especially feel happy and not need to deal with chronic wound, granulated wound for 4 years. So this is really a relief for a patient and for the patient and also for the family. And this is 3 months after operation. And then another case is a male, 45 years old, with a high voltage electric injury on both hands. So this is after fasciotomy. We could see that there are many necrotic tissue, but on the left hand, it could feel a little bit better. So on the right hand, at the time, I harvest latissimus dorsi musculocutaneous flap just to cover the effect, the exposed area here on the volar region. But the problem is the dorsal part of the hand of the wrist is getting worse and exposed bone operating. So I decided to cover with inguinal flap. But I also put a graft with the median nerve on the volar aspect. So this is the 2 years after surgery. The patient got a pathologic fracture on the radius. The wrist was broken and the hand unstable. The bone looked like a porotic bone, so I decided to do a vascularized bone graft. And the problem is fixation on the brittle bone is really challenging. So I harvest the tubular flap and then just put fixation using mandibular plate actually. So this is the result. The patient quite satisfied with the result, even though that the functional is not recover fully. Yeah. But it is still a useful hand for the patient, and the patient could conduct his duty as a Balinese prize, so using like a bell and things. Yeah. So this is really helping the patient, even though the functional is not achieved 100%. Sorry. And then also another case that high voltage electric injury with amputation, already necrosis of the second and third fingers. Yeah. So this is after amputation and fasciotomy. And then I decided to debride the wound and also cover the defect with latissimus dorsi flap. But of course, in this case, a little bit tricky because there is a healthy tissue. Yeah, this is the defect here and the defect on the wrist. So this is my design of the latissimus dorsi flap. Yeah, and this is the perforator that we identify. Yeah, so we harvest the flap. Yeah, and I also use a supercharge from the dorsal intercostal artery here, yeah, to give more vascularization to the distal part of this flap. So this is the flap when we insert into the patient, but the donor area need a skin graft because this flap is quite long and here is very difficult to close. Yeah. So this is the result, but I'm sorry that I lose follow-up of this patient, so I cannot show in the last follow-up. Another case is high voltage electric injury, yeah, direct effect of heat or heat generation causing dead limb, direct dead limb here. So we should doing amputation, radical debridement, but we should also preserve the bone as much as possible, the length of the hand, especially the elbow joint. So it will maybe help the patient when using the prosthesis and improve the function. So I did the amputation, radical debridement, and all the volar muscle and also some of the bicep muscle, but we preserve the bone, yeah, the elbow, and then I decided to use the LDMC flap as a muscle transfer by transpose the flap, yeah, with the intact vascular pedicle and also the thoracodorsal nerve. So this is the amputation, and we debride all the dead tissue, and we transpose the latissimus dorsi flap into this area. And yeah, the movement of the elbow is quite good. The patient able to flex the joint and extend the joint. Another case is a lady, a female, 40 years old with abdominal burn contracture. This actually happened during her childhood, yeah, but came to me after 40 years and the patient had 4 children. Yeah. So this is the patient coming because the inflamed scar at the first time she came, yeah, and then after we treat the inflamed scar, we decided to do reconstruction, and we excise all the scar tissue here, and then decided to use LDMC flap as a pedicle flap to reconstruct the area. So I used the abdominoplasty technique to reposition the nipple and also the breast here and the the rest of the defect we cover with the latissimus dorsi musculocutaneous flap. And this is the result 4 months after operation. Yeah, the patient quite happy with the result. And then the next step of my innovation, innovation in using this flap is make it like a compound flap. Yeah. So actually, I try to find on the AI what is actually the difference between compound and chimeric flap. So actually, this is very different. Yeah. So the chimeric flap give more mobility and also the vascular supply. They has a individual vascular branch for each tissue component. Yeah. And the compound also could be supplied by single main blood vessel, but it can also have multiple vascular sources. But the mobility is much more freedom on chimeric than in compound flap. So this is maybe a terms that I use as a compound flap, but this just I found recently what is the difference. So this is also the case of high voltage electric injury. This is after fasciotomy and we do the debridement, yeah, remove all bad tissue, and harvesting the flap as a compound flap. So there are 2 perforators. So I make it spirit perforators. I make it spirit harvesting between the skin flap and the muscle. Yeah. And this gives some mobility in positioning the flap because by using this technique, I could cover not only the volar aspect, but also the dorsal aspect. Yeah. So this is just intended to cover both sides, the volar and dorsal. So the muscle I put here on the volar and with skin graft and the skin on the dorsal. So why I use the muscle on the volar? Because I believe that the muscle has much vascularity, so that will give more vascularity and give blood supply to the compromised tissue here, the tendon and the nerve. So we hope some regeneration happen by good vascularization. So this is the insetting of the flap. Yeah. So I put the muscle here with skin graft, and the one is going to the dorsal of the hand. Yeah. So this is the result 3 months after operation. Yeah. And the donor side is quite good actually. Yeah. And but of course, it look like a bulky flap. Yeah. Because a thick dorsal skin from the trunk. And then another case is a male, 15 years old, with a motor cycle accident. Yeah. So there is a crash injury and loss of soft tissue here on the dorsal aspect. So the same concept, I use a compound flap. So I harvest the skin and the muscle with different perforators. So I have a greater mobility of the flap. So I use the muscle to cover the dorsal forearm and use the skin to cover the dorsal of the hand. So this is the muscle that we put on the dorsal of the hand, and we put skin graft, and the skin we put on the dorsal of the hand, and the third, the fifth, and the fourth and the fifth finger we cover with one in one coverage area, and then later on we split it. So this is the result 6 weeks after surgery. The muscle, and this is the skin that cover the dorsal area. But on the donor side, there is some small complication. The scar here is easily destructive. I'm sorry. So we need to do consider maybe in this case we put a skin graft, yeah, before we close it. We close too tight, yes, sometimes like this, some ulceration on the scar area. And then I develop a thoracodorsal artery perforator flap in my armamentarium. I learn a lot, yeah, from the books, yeah, and then so this is a case of a female 45 years old with a fling injury. At the first attempt, we put a skin graft on the face, on the nose, on the cheek here, but the contraction of the scar is very severe. The patient complain cannot open the mouth, especially on the right side. So we release the contraction and put uh, radial forearm flap, and the nose become blocked, and then we use the forehead flap. The last time the patient came with complaint that on the chin area, on the neck is very, very tight, and when the patient feel that the lip start pulling down, retraction of the lower lip. So I decided at the time to harvest the TDAP from the left side. But the first flap actually failed because of the venous problem. So when we salvage the flap, when I salvage the flap, I directly harvest another flap, the second flap from the right side. So this is the thoracodorsal artery perforator flaps without muscle. This is quite a big flap actually, yeah, and yeah, the skin is still the subcutaneous tissue is quite thick also here. So we anastomose the pedicle, yeah, and this is the result of the flap, yeah. The flap could survive and showing yeah, of course it's look like bulky flap. And then we do some revision, thinning of the radial forearm flap, and also some thinning also on the chin area, and use of the elastic garment. Yeah, this is 2 years after surgery. The patient came to me, and the keloid on the ear is very, very prominent. Yeah, so yeah, this is the result of the thoracodorsal artery perforator flap that we put on the chin and on the neck area here on this patient. But the function is good. The patient able to open the mouth. Yeah. Neck is also the bone contraction on the neck affecting a female 46 years old. So the patient actually has a limb, lower limb contracture, hand contracture. But here we discuss about the neck contracture that I did release at size of all the scar tissue, and prepare the recipient vessel just from here, from the superficial temporal artery. This is up to release of the flap, and we harvest the thoracodorsal artery perforator flaps, yeah, and we anastomose into the superficial temporal artery. So this is the result of the flap actually. Yeah. The patient we plan to do another reconstruction on the hand, but I take this picture for the flap that is on the neck of the this is a thoracodorsal perforator neck or perforator flap. This is another case of female, 45 years old. This is a spiroadenocarcinoma in the facial region, and then we join with the neurosurgeon doing excision, radical excision of the tumor. And this is quite a big defect actually, so that's why I choose also the thoracodorsal artery perforator flap to cover this area. And this is the result coverage. Yeah, this is just simply to cover the defect. And then thoracodorsal artery perforator flap could also be harvested and transposed into the defect as a pedicle flap. Yeah. So this is a boy, 15 years old, with many contracture on the neck and other part of the body. But I show here the axillary region, the contracture here. So I also doing reconstruction using the thoracodorsal artery perforator flap. Sorry. And we use as a pedicle flap, transpose into the axilla here. So release of the contracture with some set design, the plastic design, and we harvest the thoracodorsal flap here, and we transpose to this defect area. So this is a pedicle flap. So this is the result. The patient able to detect the hand, yeah, and the flap is good. This is also another type of axillary contracture that we could use. The thoracodorsal artery perforator. So this is the perforator. Based on this perforator, we release the axillary region here, and we transpose the flap into this area. But because of the defect here is quite long from the wrist, yeah, until the mid or the top of the arm here. So we do release, but on the same time, I cover the defect with ALT for the forearm area and skin graft for the arm area here. And the donor site on the thoracodorsal artery here is also we need the skin graft here. We transpose here as a pedicle flap. So this is the result of the flap, the transposition of the pedicle flap of thoracodorsal artery perforator. In the children, we also harvest TDAP as a thin flap. This patient is a male, a boy, 9 years old, suffer from flame injury with unstable scar and chronic granulation tissue, flexion contracture of the popliteal region. So we do release the contracture and harvested the flap from the thoracodorsal. I harvest here. Yeah, it is quite thin flap in children, so we could harvest a long pedicle. And this flap actually at the first a few days after surgery developed some venous problem, and then we do some leeches therapy and some graft also leases. So we put another skin graft, yeah. And this is the result. This is the flap was certified. Yeah. and the patient able to walk again. Yeah. And I also have to another case, but with a problem of this venous problem, and the patient fail, the flap is fail. Yeah. But in this case, it's the result is good, even though have venous problems. And this is the last what I learned from Koshima, the chimeric flap, yeah, in using this type of latissimus dorsi flap. Yeah. So this is a male, 63 years old. He got motorbike accident 3 years before. So for 3 years, the patient with exposed plate and screw and always sequester coming out from the wound. And also the patient has have a fracture on the femur with the same problem, sequestration from the right femur here. So I just thinking, so how we doing reconstruction in this case? For the femur, because this is a long bone, yeah, a long defect here, definitely I need a long bone graft or bone flap. So my plan is harvest the fibular flap from the left from the left cruris to reconstruct the femur. But for this here on the cruris area and exposed plate here, so I think the defect is not quite long. So I think this could be reconstructed using the chimeric flap from the LD muscle with the scapular flap. This case is actually just 4 days ago. I did it 4 days ago. Yeah. So we remove the plate and screw here, and then I use VAC or NPVT for 1 week because the wound is quite long time. So the osteomyelitis and infection, biofilm and everything will be difficult to manage if we just directly reconstruct the area. So I think that I need to prepare the wound first. Yeah. So when the wound getting better, granulation, and then I start to reconstruct with the free flap. So I harvest the LD flap. Yeah, but I'm not able to really what harvested really thin muscle. Yeah, so this is just a part of the muscle. Yeah, split muscle that we still use, still attached on the flap, and this is the scapula. So the scapula is the long around 6 centimeters of the scapula that we harvest from this latissimus dorsi and also the subscapular system to the scapula. So this is the result for this go now. The patient still on ward. Yeah, so yeah, the flap is for the moment is still good. Yeah, and here the fixation, because the infected wound, I'm quite worry. I put a big flit here, so just put a screw, yeah, and fit and hold the bone graft using the mandibular plate. Yeah. So this is the scapular that we take from the for this defect reconstruction. So that is my learning curve. So thank you so much, and we will hosting Asia Pacific reconstructive microsurgery meeting on 2026. So I hope that you could join us in Bali next year. So thank you for
Thank
the
you,
attention.
Professor. and
Thank
for nice talk. I can
you.
imagine the skill and temperament and the patience required to deal with the burns patients. It's amazing work. Thank you. I would like Professor Koshima to have any view about. Uh,
Yeah, yeah, amazing, amazing. Yeah, you have a very severe case.
Mhm.
Yeah, in Japan, this kind of severe case probably are now not so many, very rare. But yeah, in your country, many patients are waiting for your microsurgery. Anyway, you enjoying the LD from LD to top. Yeah, this is the probably a young generation that will enjoy from now, completely same as you. Yeah, some of the LDMC is not so interesting because it's very easy. But top rap is very interesting. Always rich with the scare. Yeah, and also the great advantage may be no need to the positional change. So this is a great advantage. With positional change, we lost maybe 30 minutes, and yeah, so continuous surgery is very important. Yeah, positional change always interrupt our enthusiasm. So this is the very important. When I started head and neck reconstruction using ALT, yeah, the ALT great advantage ALT is we can do continuously. No need to stop. So that's why this concept is very important for long time micro reconstruction. Also, probably yeah, some modification. Maybe, I also doing completely same as you when I studied, top rap. But, year by year, my, concept and technique change. I use a banking concept. So tap, we can transfer, a large volume of tap wrap. So enough volume transfer, enough amount of volume and banking, bank the recipient side. And always we need additional coverage. So this banking tap wrap could be transferred to second stage other area, other contractors. And so also fatty tissue become atrophic. So flap dimension become wider. So banking transfer, flap on flap transfer is possible. So that's why the first case you show me labial contracture still existed. So this could be easily repaired with banking concept. You transfer ALT, little bit big ALT. So this ALT could be some excess flap transfer as bilobe flap. One stage bilobe may be possible, but time are necessary, so a little bit long. So second time or multi-stage banking, splitting, flap on flap, technique. So we can repair the other contract area, lower eyelid, and also upper eyelid, also labial contracture. Everything could be repair with this banking concept without any additional pre-flap transfer. So this is very easy. Also very safe, short time surgery, every time, short time surgery. So I recommend the banking concept and also also if tap flap is not so enough. In that case, sometimes I show you combine tap and skip. Yeah, this is very best flap because donor side could be closed directly. Also, very long flap, over 50 centimeter, could be survive. So young women or children combine, tap and skip is probably a best flap. Also, upper arm, usually a very severe case of upper arm, whole area of upper arm need a flap. Those cases combine this tap and skip cover the whole area. But if you need furthermore, width, in that case, without the skin graft of the donor side, maybe 10 centimeter, the maximum width transfer. And if more wider flap necessary, in that case, tissue expansion, expander use in the recipient size in the second stage. So you can cover whole donor recipient. So expander and also combine connected flap is next step, but it needs multi-stage surgery. But probably everybody who's doing the long time reconstruction, everybody go to the aesthetic. So probably donor side, always pay attention to donor side. So donor side should be closed directly. So that's why multi-stage surgery are necessary. And donor side is also very important. So this is my comment. Yeah, probably year by year, this other concept, banking and jumping, and also already I mentioned the jackknife flap, skip or tap jackknife is also very important. Also LT jackknife also could be possible. Anyway, trunk area is the best area to close. Wider flap could be easily closed compared to LT. So that's why I recommend tap and also skip from trunk area. Donor side could be easily closed directly. LT is a little bit difficult. Yeah. Okay. Anyway, your case is probably no so. Yeah, no one has such a big case. Yeah, only you have such a big case. Yeah, thank you very much. Yeah, amazing.
Thank
Probably
you.
other one also has a question.